Hello everyone. Welcome to the AURA block of the video month series. Today I will be talking on PNS guided approach to brachial plexus. I am Professor Dr. Ritesh Roy, Clinical Director and Head of the Department, Care Hospitals, Bhubaneswar, Orissa. So coming to the brachial plexus provides innervation to the entire upper arm. The it is supplied, the brachial plexus is formed by the ventral ramus of four cervical and one thoracic vertebra, starting from the ventral ramus of C5, C6, C7, C8, and T1. The C5 and C6 ventral ramus comes out of the intervertebral foramina and join to form the upper trunk. The C7 continues as a middle trunk, and C8 and T1, they join to form the inferior trunk. At this level, at the level of roots, here you give the PNS guided approach to the brachial plexus, that is the interscalene approach to the brachial plexus. Then the tree trunks, then they divide into anterior and posterior divisions, and just above the clavicle, you have the trunks and the divisions. And here you have another approach, that is the PNS guided supraclavicular approach to the brachial plexus. Then again, below the clavicle, all the three posterior divisions, they join to form the posterior cord. The anterior division of upper trunk and middle trunk, they join to form the lateral cord, and the anterior division of the inferior cord, it continues as a medial cord. And just below the clavicle, between the clavicle and axilla, here you give the PNS guided infraclavicular approach to brachial plexus. At the lateral border of the pectoris minor, the terminal branches comes out. The three terminal branches, that is the radial nerve, the median nerve, and the ulnar nerve, they remain with the artery in the neurovascular bundle, but the musculocutaneous nerve, it leaves the neurovascular bundle to insert into the coracobrachialis muscle, and finally they go down and provide innervation, the dermatomal innervation, the myotomal innervation, and osteotomal innervation to the entire arm. So the axillary approach to brachial plexus is the blockade of these four terminal branches, that is the musculocutaneous nerve, the radial nerve, the median nerve, and the ulnar nerve. So, as I told earlier, the axillary approach to brachial plexus blocks the four main terminal branches, that is musculocutaneous, the median nerve, the ulnar nerve, and the radial nerve. So what are the indications of axillary approach to brachial plexus? Anesthesia and analgesia of forearm and hand surgery, with or without tourniquet, are the indications for axillary approach to brachial plexus. People have used this approach in outpatient clinic. Also, chronic pain, people are using it in their practice, the axillary approach to brachial plexus. So any block which you plan, you have to know the dermatomal innervation, the myotomal innervation, and the osteotomal innervation. So coming to the forearm surgery, the dermatomal innervation is by the musculocutaneous nerve, the radial nerve, and medial cutaneous nerve of forearm, which comes from the medial cord. The myotomal innervation is from the radial nerve, the ulnar nerve, and the median nerve, and the osteotomal innervation is by the radial nerve and median nerve. And axillary approach to brachial plexus block can take care of all the dermatomes, myotomes, and osteotomes relevant to the forearm surgery. Now coming to the hand surgery, the dermatomal innervation is by the ulnar nerve, the radial nerve, and the median nerve. The myotomal innervation is by the radial nerve, ulnar nerve, and the median nerve, and the osteotomal innervation is by the radial nerve and the medial nerve. And axillary approach to brachial plexus block can take care of any surgery on the hand, because it can take care of the dermatomal innervation, the myotomal innervation, and the osteotomal innervation. So if you combine for any surgery, you have to take care of the dermatomal innervation, the myotomal innervation, and osteotomal innervation of that area. If any of the thing is missed, your patient might scream in pain as the surgeons give incision or during the course of the surgery. So coming to the functional anatomy, the axillary artery is the most important landmark in a PNS guided approach to brachial plexus, because in 65% of the population, the four nerves, they maintain a predictable orientation relative to the axillary artery. This is a very good article which came in 2006-9 by Christophe, assessment of topographic brachial plexus nerve variation at the axilla using the ultrasonography. And what he found, in 65% of the population, you will find the median nerve if you divide this quadrant into the upper quadrant and lower quadrant, and again you divide into superficial quadrant and deep quadrant, the median nerve lies in the upper superficial quadrant, usually at 11 o'clock position. The musculocutaneous nerve lies in the upper deep quadrant inside the coracobrachialis at around 9 o'clock position. The ulnar nerve lies in the superficial deep quadrant at around 2 o'clock position relative to the axillary artery, and the radial nerve lies in the lower deep quadrant at around 5 o'clock position relative to the axillary artery. This type of topographic arrangement usually you will find in 65% of the population. And if you see the median nerve, the ulnar nerve, and the radial nerve, they lie inside the neurovascular bundle along with the axillary artery. The musculocutaneous nerve has left the neurovascular bundle. It is outside the neurovascular bundle, and it usually lies inside the coracobrachialis muscle or between the biceps and the coracobrachialis muscle. So you have to remember the orientation of the relevant nerves around the axillary artery for a successful PNS guided approach to the axillary brachial plexus block. So coming to the cross section of arm high in axilla, where axillary block is usually performed. So as I told, if you divide the quadrant into upper quadrant and deep quadrant, you will find the median nerve in the upper superficial quadrant. The musculocutaneous nerve usually lies in the upper deep quadrant. So you can approach both the median nerve and the musculocutaneous nerve by a same puncture site above the artery. If you put the needle at a shallow angle of 30 degrees to the skin relative to the artery, you can approach the median nerve, and that same needle, if you orient around 45 degrees towards the patient head, you can approach the musculocutaneous nerve. Similarly, the ulnar nerve lies in the lower superficial quadrant, and the radial nerves lie in the lower deep quadrant. And you can approach both the radial and ulnar nerve by the same puncture site below the artery. You can put the needle at a shallow angle of 30 degrees to the skin to approach the ulnar nerve, and the same needle you can insert at around 45 degrees posterior to the artery, and you can approach the radial nerve. So you have to remember this topographic arrangement of the four nerves relative to the axillary artery. So coming to the block procedure, if you see the equipment which you require a sterile glove, a marking pen, the skin electrode for the PNS, the sterile towel and gauze, 2 ml and 10 ml syringe, 50 mm insulated stimulating needle because it's a superficial block. You don't require a longer PNS needle. The peripheral nerve stimulator. And if you have got an opening pressure injection monitoring device, if it's available, it's better to use it so that you can prevent nerve injury. So what is the PNS setting? Initially, we usually start with a current of around 1 to 1.5 milliampere at a frequency of 1 to 2 hertz or Sensi mode if your PNS machine has, with at a pulse duration of 0.1 millisecond, and the acceptable motor response is usually taken at the current of 0.4 to 0.5 milliampere. But always reduce the current to 0.2 milliampere to check for motor response. If you are getting a motor response at 0.2 milliampere, it means your needle is inside the nerve. So readjust your needle. You should never get a PNS response, nerve motor response at 0.2 milliampere. The acceptable motor response is 0.4 to 0.5 milliampere, not 0.2 milliampere. Please keep this thing in mind to prevent intraneural injection. So what is the LO volume and concentration? It depends whether you are using the technique for a surgical anesthesia or postoperative analgesia. If you are using for a surgical anesthesia, you can use ropivacaine 0.5% or bupivacaine 0.5%, 25 to 30 ml. And if you are using for a postoperative analgesia, you can go down on the concentration to 0.2% of ropivacaine or 0.25% of bupivacaine. But always watch for last. So what is the patient position? The patient usually lies supine. The arm is abducted 90 degree. Elbow is flexed at 90 degree. The tip is don't abduct the shoulder more than 90 degree as the axillary artery palpation becomes difficult and the increased risk of nerve injury, because as you abduct your shoulder more, as you abduct the shoulder of the patient more, the nerve comes more superficial and there are chances that you can injure the nerve while putting the needle. So what are the landmarks and needle insertion site? Mark the highest point of axilla. Palpate the pec major muscle and mark it. Palpate the triceps and mark it. Palpate the biceps and mark it. Palpate the coracobrachialis muscle and mark it. The pulsation of axillary artery is usually felt below the coracobrachialis muscle. So palpate the pulsation, feel for the pulsation and mark it. After marking the axillary artery, mark 2 needle insertion site. 1 needle insertion site above the axillary artery for the median nerve and musculocutaneous nerve. 1 needle insertion site marked for the below the artery for the radial nerve and the ulnar nerve. So coming to the block technique. So for the median nerve, the needle is inserted above the artery at a shallow angle of 30 degree with an initial current of 1 milliampere. And you want an acceptable end motor response is 0.4 to 0.5 milliampere. What you want to see, you will see the flexion of first 3 fingers or wrist flexion or pronation. If you get any of these response, take it as an acceptable response at 0.4 to 0.5 milliampere. Reduce the current to 0.2 to see whether your needle is not intraneural. Increase the current and inject around 5 to 7 ml of local anesthetic. And after injection, your motor response stops. This is the positive Raj sign. It means your drug has been deposited in the right place. For the musculocutaneous nerve, the same needle which was used for median nerve is inserted towards the patient head at an angle of 45 degree, and the acceptable motor response is bicep contraction or elbow flexion at 0.4 to 0.5 milliampere. If you get the elbow flexion as 0.4 to 0.5 milliampere, inject around 5 to 7 ml of local anesthetic, and as you inject, the motor response stops. This is a positive Raj sign. Now, for the ulnar nerve, the needle is inserted at a shallow angle of 30° below the axillary artery. And what is the response which you want to see? The response which you will want to see is either thumb adduction, ulnar deviation of hand, or flexion of last two fingers. If you get any of these response at 0.4 to 0.5 milliampere, inject around 5 to 7 ml of local anesthetic. And as you inject, your motor response goes off. It means your drug is deposited in the right place. This is a positive Raj sign. So these are the three responses which you will want to see for the ulnar nerve. For the radial nerve, the same needle which was insertion site, which was for the ulnar nerve, the needle is angulated at around 45° and you have to go posterior to the artery. As you start putting the needle inside, you might see the triceps contraction. Never ever accept this response, the triceps contraction. It means you are stimulating one of the branch which is supplying to the triceps. The acceptable response is either a finger extension or wrist extension. If you are getting finger extension or wrist extension at 0.4 to 0.5 milliampere, accept that response and inject around 5 to 7 ml of local anesthetic. So by this, we have completed the injection of all the four nerves. We have stimulated all the four nerves and injected around 5 to 7 ml of local anesthetic near the respective nerve. So what is the clinical pearl? The triple injection axillary block is the most efficient technique. If you have a time constraint, you can inject around the radial nerve, the median nerve, and the musculocutaneous nerve. If you inject around these three nerves, usually the ulnar nerve can be taken care of. The separate ulnar nerve injection is not mandatory. Now, as I have told you for the forearm surgery, as I have told you for the forearm surgery, the dermatomal innervation is from the medial cutaneous nerve of forearm, which is a direct branch from the medial cord. So how you take care of that? Usually the musculocutaneous nerve of forearm runs along with the median nerve when it enters the axilla. So if you are depositing around the median nerve, the musculocutaneous nerve of forearm is also blocked. Now, this article, which came in 2016 by Kiji Chin, they had seen a single, double, or multiple injection technique for non-ultrasound guided axillary brachial plexus block in adults undergoing surgery of the forearm. The author came to a conclusion that multiple injection techniques using nerve stimulation for axillary plexus block produces more effective anesthesia than either double or single injection technique. So the multiple injection technique is the most effective approach for PNS guided approach to brachial plexus block. And if you are selecting multiple injection and you have got time constraint, you can block the radial, the musculocutaneous, and the median nerve. Ulnar nerve, usually you can skip if you have a time constraint. Axillary artery palpation might prove challenging in some patients. If you have got a very patient with a thick arm and sometimes the axillary artery palpation becomes challenging, the first motor response will guide the subsequent needle redirection to achieve the blockade. Suppose you have inserted the needle at the highest point of axilla, and you are not able to appreciate the axillary artery palpation, and you are getting a musculocutaneous nerve response, it means your needle is outside the neurovascular bundle and you are much higher superficial to above the artery. You have to bring your needle down to block the median nerve, the radial nerve, and the ulnar nerve. Suppose you have inserted the needle and you are getting a median nerve response, it means your needle is above the artery. Suppose you are not able to palpate the axillary artery and you have inserted the needle and you get a radial nerve response, it means your needle is below the artery. The subsequent needle insertion can be guided depending on the first motor response. The more difficult differentiation is between the median and ulnar nerve because both result in wrist or finger flexion. In this scenario, the following methods can be used to differentiate between the two nerves. If you are getting a finger flexion plus forearm pronation, it means it's a median nerve response. Or suppose you are having a difficulty in identifying the median and ulnar nerve response, the palpation of flexor tendon at wrist can help you. With a median nerve stimulation, movement of palmaris longus and flexicarpalis radialis tendons occurs. With a ulnar nerve stimulation, you can see the movement of flexor carpi ulnaris tendon. So, by palpation of the flexor tendons at the wrist, you can know whether you are stimulating the median nerve or you are stimulating the ulnar nerve. So, what is the advantage of axillary approach? It is suitable for patients with severe respiratory disease because there is no chance of lung injury, no chances of phrenic nerve palsy, no risk of pneumothorax. It is also suitable for patients with mild coagulopathy because the puncture site, the axillary artery, is easily compressible. Suppose you have accidentally punctured the axillary artery, you can compress and you can stop the bleeding. So what are the troubleshooting? Arterial blood in the tubing or venous blood in the tubing. So always aspirate before injecting your local anesthetic. Stimulation of biceps and triceps muscle. If you are stimulating the biceps, it means your needle insertion site is much higher compared to the axillary artery. If you are stimulating the triceps muscle, it means your needle insertion site is much lower compared to the axillary artery. You have to put your needle slightly up. Paresthesia, if you are getting a paresthesia, it means you are near the nerve, you are injured, your needle is touching the nerve. So readjust your needle. So what are the possible complications with axillary approach? Vascular puncture, apply pressure for 5 minutes. Hematoma, avoid multiple needle insertion in patient on anticoagulants. LA toxicity, because always aspirate before injecting and always calculate the safe doses of local anesthetic. Nerve injury, because these nerves are quite superficial here, there are chances of nerve injury. So do not inject if high resistance or patient complains of severe pain of injection. And when you obtain a motor response at a current of 0.3 or less or 0.2 or less, readjust the needle. It means your needle is inside the nerve. Or if you have got a pressure monitoring device, use it for your injection. You can prevent nerve injury. So what is usually you don't have much of the contraindication with axillary approach to brachial plexus. If there is a local infection, avoid that approach to brachial plexus. Or if the patient is sensitive to local anesthetic, don't give the don't use that local anesthetic. Or patient on anticoagulant is a relative contraindication because, as I told you, this is a superficial site. You can easily compress if you have done a vascular puncture. Thank you. Thank you for your kind attention. Thank you very much.